So the procedure was essentially created or invented in the mid-2000s, probably around 2004, 2005. And so here at UCLA, I've been doing this here for the last 4 years. Basically, it's an endoscopic procedure for revising a Roux-en-Y gastric bypass procedure. We know that millions of Americans have gone through a gastric bypass operation, and it's a great step in terms of treating obesity and diabetes and so forth. But we also are starting to learn that many patients are regaining weight and having a recurrence of comorbid conditions like diabetes, high blood pressure, and arthritis. And this is actually a growing population in this country because so many patients are undergoing the operation. Many of these patients are left without a viable treatment. Really, the only treatment they have is diet and exercise, which we know is not very good. Surgeons are often reticent to have patients undergo a revision operation simply because there is a higher risk profile associated with the revision operation itself. And also patients are a little reticent to undergo another sort of operation. So we came up with the idea that perhaps we can revise the operative anatomy through purely endoscopic means. We know that a small pouch is created during the operation, and usually this is anywhere from 15 to 30 cc's immediately postoperatively. But what we've learned is that the pouch itself can actually dilate and stretch over time, and also the outlet, so the gastrojejunostomy, will actually stretch as well. And we found that on multivariate analysis that this is independently associated with weight regain. So the idea behind the procedure is that we have patients undergo a standard endoscopy, so this can be performed with moderate sedation. Usually we'll have a monitored anesthesia care. And patients will undergo a standard endoscopy, and we'll evaluate that pouch anatomy. And essentially what we're looking for is to see whether the pouch itself is stretched and whether the stoma has actually dilated. And if that's the case, we can actually use endoscopic suturing devices to reduce the size of that stoma as well as the pouch. It's actually quite a, for lack of a better word, benign procedure. So the risk profile is similar to that of a standard endoscopy. So certainly there's always risks associated with a patient undergoing sedation. When we're doing an endoscopy, there's always a theoretical risk of a perforation or bleeding. But the procedure itself actually has not resulted in any increased risk profile other than a standard EGD or endoscopy. So the patient can basically fast overnight, take their morning medications, come in for the endoscopy. The procedure itself can take anywhere from a half hour to an hour and a half. They'll be recovered in the recovery area, and essentially most patients will go home that day. So it's really a come and go or outpatient procedure. And then in terms of return to function, most patients can return to work within 2 to 3 days. So there's a minimal impact there. Generally, the cash payment is somewhere in the order of $8,000 to $10,000. It kind of depends on the hospital and the regional specifics. Most insurances will cover this, although it does require some effort on behalf of the treating physician to proactively discuss this with the insurance providers to come up with coverage for it.